Welcome to Chronic Things. In this episode, I talk to Dr. Adrian Soto, a medical doctor and a PhD. We cover migraine, and we cover it in a fairly broad way. We look specifically at dietary interventions, so this is ketogenic diet. We look at metabolism and other diseases that are linked to metabolism, such as obesity. We look at biomarkers as well and how patients may be categorized by their biomarkers, or the patient migraine might be categorized by biomarkers. And we also look at oxidative stress and how one of the underlying causes for migraine may well be oxidative stress. I really enjoyed recording this podcast. It was interesting to talk to Dr. Adrian, and I'm hoping to have him on again soon. Let me just do. Okay, cool. So yeah, I appreciate you coming on. And I wonder if, before we really get into things, I wonder if you could just sort of give us a brief overview of your sort of background and your sort of your past, really.
Sure, of course. Thanks for inviting me. I'm always happy to talk about my research. I was born and raised in Mexico City. I earned my medical degree in Mexico, and I specialized in internal medicine. Not all countries have internal medicine. So, for example, when I was in the UK, they didn't have a good notion about what internal medicine is. And if that's the case, an internist is like a pediatrician for an adult. So if you have, if you're a child, you go to a pediatrician. If you're an elder, you go to geriatrics. If you're in between, you come with us.
Yeah.
So I specialized in internal medicine, and of course, because of the shape metabolic diseases have in today's world, and because of their frequency, most of what we see as internists is chronic metabolic diseases. After finishing my residency years, I earned my PhD at Oxford, studying ketone metabolism, and I specialized in data analysis and data science methods. And I came back to Mexico City, and I work as a clinical researcher at Mexico's equivalent of the NIH, the National Institute of Health and Medical Sciences in Mexico City. And my research scope, my research lines are on dietary interventions, many times carbohydrate restriction for different chronic illnesses, and the use and abuse of statistics-based clinical decision tools. I mean, perhaps not all patients are aware of that, but modern clinicians typically take out their phone and go to a MedCalc website where there are scales and calculators for different things. The idea is to make a more objective evaluation and to support clinical decision making. And of course, some of these tools are, as with any other large set of tools, some of these tools are great, some of these tools are awful. And I like to do research on how to appropriately use these clinical decision stats-based clinical tools.
Okay. And so you say part of your previous research as well was looking at sort of dietary interventions for chronic diseases.
Most in Mexico, obesity is super prevalent. We have a similar prevalence as what you would observe in the United States. We have a very high prevalence of diabetes. We have a very high prevalence of hypertension. And of course, there is a link between these chronic illnesses, which is disease to metabolism. If you had to choose one thread that is intertwined in all those chronic diseases, you would have to big insulin resistance, of course. So that's what I mean when I say metabolic chronic illnesses. And of course, that's something that I would like to, I mean, perhaps I'll take that as my cue. Migraine is, in many cases, metabolic chronic disease. We are not saying in the paper we will talk about that all migraines are metabolically originated, or that all patients living with migraine have a diseased metabolism. But we believe there is a relevant subset of migraine patients who would benefit from improving their metabolic health, not only because of the benefits of improving your metabolic health, but also because that would likely improve your migraine symptoms. So that's what I mean when I say that migraine can also be a chronic metabolic disease.
Okay, and I mean, so from sort of looking at your paper, as near as I can tell, you seem to have found a metabolic migraine subgroup with obviously specific signatures, and these signatures are sort of blood markers. So C-reactive protein being one, hemoglobin A1C being another, and phosphorus being another one. And is it so you have this interest in different chronic diseases? Was there any particular reason you had an interest in migraine, or was it the case that you saw that there was an opportunity for sort of this kind of research, and or was your sort of interest very sort of geared towards migraine?
I mean, I would have to say it was a bit both. And in all fairness, I shouldn't claim that it's a subgroup of migraine patients that we found in this particular paper. I mean, the notion for a metabolic subgroup of patients precedes our paper. And perhaps who has done more research about it is Dr. Elena Gross, who I met at Oxford, and we started collaborating there. She has a very nice Nature review on metabolic migraine, which I would highly recommend for those who are interested in the more molecular details. And in that review and in research she has also worked in, it's very clear that, for example, the brains of people living with migraine have trouble with energy production, or that insults that alter either energy production or reactive oxygen species production are linked with their migraine symptoms. On the other hand, there's also a relevant body of knowledge of people improving migraine symptoms with ketogenic diets. And I mean, I think I can talk about that openly because she's very open about it. But Elena, Dr. Elena Gross, lived with migraine and she improved her symptoms with a ketogenic diet. And if you go to the literature, there is, I mean, a good amount of studies where not only symptoms improve, but also tangible physiological and electrical changes occur when you shift your diet that precede these symptom improvement. So that's what I mean when I say that it's not like this was the very first paper that showed that migraine could be, that there could be a metabolic subgroup in migraine patients. This body of knowledge already existed. The contribution of our paper is to try to pinpoint which are the biomarkers that are more closely linked to identify the subgroup. Because the metabolism, I mean, metabolism is so broad that, I mean, you have tons and tons and tons of different molecules, and it's not entirely clear which ones are the useful ones to identify, oh, I am someone living with migraine and a deranged metabolism, and perhaps if I fix my metabolism, my migraine will improve as well. So that's a contribution of this paper, to try to pinpoint which of all the metabolic markers you would get in a blood panel are the useful ones to identify who is likely to benefit from a metabolic intervention for migraine.
Mm-hmm. Yeah, your paper to me was also quite interesting because it parallels some of the cancer research papers that I've seen quite recently that use similar methodologies. In other words, they look for specific metabolic markers. In this case, it's usually some blood-based marker, for example. With cancer, obviously, it tends to be sort of cell-free DNA or some other sort of DNA or RNA. But you do have obviously other blood-based markers as well. And they tend to, as you've done, compile this information or these marker values across patients and then attempt to apply some model. For example, logistic regression, some other model, random forest, XGBoost, so forth, to then try and come up with, for example, a subset of markers that can distinguish whatever it might be that they're trying to distinguish. So in cancer, it tends to be, obviously, do you have cancer, yes or no, kind of thing. So usually it's either a binary classification system, or maybe you have a sort of third class in there. So your study I found quite interesting because it very much reminded me of that. And I've certainly seen other research as well, and this approach always seems sort of quite nice to me in that regard, and maybe because in some sense it's very easy to follow what you did, which you can't necessarily say for a number of papers. So I must admit I quite like that. And you mentioned you mentioned the whole sort of ketones can or the ketogenic diet can be used to in some individuals reduce the burden of migraine. I wonder, would you say that sort of oxidative stress is one of the underlying migraine triggers as well?
Yes.
Okay.
Oxidative, I mean, for those who are perhaps not as familiarized with oxidative stress, you could say is something. Reactive oxygen species are substances that are produced whenever and wherever we are burning energy that can affect the function of different molecules. So oxidative stress is very closely linked to aging, to inflammation, to cancer, and it's a reality of our metabolism. Every time you are producing energy or burning energy, some reactive oxygen species will be produced. And our understanding of migraine biology suggests that things that could increase the production of reactive oxygen species perhaps trigger migraine flares through these mechanisms.
Okay, and I think one of the other sort of questions I had for you actually before I forget is, so you used beta hydroxybutyrate and to sort of just kind of test its effects on migraine, so to speak. I wonder if you could just sort of quickly describe what beta hydroxybutyrate is, and
Sure.
your reasoning behind why it might be useful in this context.
Sure. Beta hydroxybutyrate, most commonly referred to as BHB, is one of the three ketone bodies our body produces, our physiology produces. So when insulin is low, you produce acetone or acetoacetate or BHB. Actually, you produce all three of them. It's not one or the other. So you produce these three ketone bodies. Acetone is mostly lost in your breath. Acetoacetate is actually the active form of ketone bodies, the one that can undergo energy oxidation, carbon oxidation. And BHB is sort of the intermediate molecule, but it's of these three ketone bodies, the one that's more abundantly produced. And there are, I mean, without getting too technical about ketone body biology, BHB is important because not only because of its abundance, but also because it has signaling properties. It's a chemical messenger, like insulin, like many other hormones. Actually, I like to harass endocrinologists telling them that BHB is the most important hormone they never heard about, because it has two cell membrane receptors that have been clearly identified. It combined itself to histones and change DNA expression. It influences many transcription factors. I mean, it has a very wide range of physiological activities beyond its role as a fuel. So that's remarkable when you think of other typical physiological signals in our body. And part of the rationale of producing more BHB than the active form, which is acetoacetate, is precisely to produce a lot of this messenger that will help coordinate the rest of the tissues. So because you need to change the behavior of different tissues, it makes sense to produce lots of that. It's like sending, if you want to send a memo, you make sure you send enough for everyone to receive it. So it's pretty much the same idea. So even when BHB is not the active form of ketone bodies in the sense of carbon oxidation, it's the most important one because it has signaling properties. And one of the things of BHB is that, and this is a recurrent topic in our paper, it's fairly easy to measure. And you don't want a marker that's super hard to get or very expensive to measure. I mean, let's talk nonsense. Imagine we had found that kryptonite in your tears is a fantastic marker for migraine. Well, who cares? I mean, I don't have a kryptonite assay in my local drugstore, or even if I did, perhaps it's not even remotely linked to the physiology of the disease. So you want markers that are linked with the physiology or pathophysiology, but you also want markers that are fairly easy to get and reliable and well standardized. And that's why BHB is an attractive marker for metabolic migraine.
Okay.
And also an intervention. I mean, let me make a small parenthesis there. It's not only a good marker of a ketogenic diet, it's an active area of research to see if giving BHB could help ameliorate migraine symptoms. Because now there are BHB supplements. And yes, lots of people have improved their symptoms with a ketogenic diet. But I mean, some people may want to eat differently or are not good candidates for a ketogenic diet. So there's always room. And this is an open question. We still don't know if supplements will work as well as a diet. But that's why BHB is interesting as a potential intervention and as a biomarker.
Okay. And I think you mentioned that BHB, it has, say, I would imagine multiple effects on different tissues throughout the body. And it seems that some of those effects are to help prevent, say, migraine in some regard. I wonder, without getting too technical, is it the in terms of migraine prevention with BHB, is it the sort of what would you say, the energy system that the BHB is affecting in terms of migraine reduction? Is it the sort of, is it a reduction in inflammation?
The honest answer is we don't know. We think those are plausible explanations. And my bet is that, as with many other things in human physiology, there is more than one simultaneously correct answer. Very, very few things in our body have only one task or only one effect. I mean, perhaps what's true for enterprises is true for our body. If you are important, you certainly have more than one job or more than one task. So in our body, almost everything, if not everything, has more than one job. Otherwise, it wouldn't be there. Yeah. And that's why I think that there isn't a single mechanism on which ketogenic interventions could be working their benefits. But to be honest, we don't know exactly which one is the most important, what's the magnitude of each one of these mechanisms. But what we understand of ketone body physiology makes us think that there is more than one plausible answer for that. Inflammation is certainly a good example. Let me go a bit away from migraine. A common question in different diseases that improve with ketogenic interventions, because, for example, diabetes is perhaps a classic example. Diabetes has fantastic results, type 2 diabetes, and actually type 1, there's some anecdotal evidence in type 1 as well. You can even put diabetes into remission with ketogenic interventions, which is, of course, huge. But it was still an open question when I started my PhD. What was the mechanism? Because we knew that carbohydrate restriction, the carbohydrate restriction part of a ketogenic diet, could be the mechanism. But we also knew that ketone bodies themselves lower blood glucose. And these have been observed in different animals with different ketone bodies, both acetoacetate and BHB lower blood glucose within minutes. So it was an open question. What's driving the most part of these benefits that we observe in diabetes? Is it BHB itself, or is it the carbohydrate restriction? So part of my PhD was about answering that question. It's definitely the carbohydrate restriction part. But there are good arguments in migraine and other neurological diseases to think it could be ketone bodies themselves. For example, in epilepsy, work done at Dominic D'Agostino's lab shows that ketone bodies themselves have some, can improve seizures. And I think this is still an open question for migraine. It could be that ketone bodies themselves are driving the most part because they are anti-inflammatory signals. But it could also be that it is a carbohydrate restriction part. And of course, it could also be that for some patients is one and for other patients is the other. So that's why I'm always an advocate for nuance. And even when our brains love simplistic answers, there are multiple plausible mechanisms. And what we understand of both ketone body biology and carbohydrate restriction biology makes inflammation or direct energy changes plausible mechanisms.
Regarding the sort of carbohydrate and inflammation, this is not to go off on too much of a tangent, but do you think that insulin spikes would potentially be related to inflammation? In other words, what aspect of the carbohydrates is linked to inflammation? Do we know at all?
Yeah, insulin is one of my favorite topics because what most people know, actually most clinicians know about insulin, is that it's the hormone that makes glucose go into cells and away from your bloodstream. That's what everyone was taught in med school, and that's of course true. However, I like to say that saying that insulin's job is to lower your glucose is like saying that your skin's job is to make hair. I mean, some skin makes hair, sure. All skin makes hair? No. Would you die if your skin stops making hair? Fortunately, no. So, I mean, it's true, but it's hardly its most important task. It's hardly its most important job. Your skin is involved in defending yourself, in keeping heat, in keeping your temperature where it's supposed to be, your hydration where it's supposed to be. Insulin has so much jobs, so many jobs, and many of them are arguably more important than lowering your glucose. Many clinicians actually forget that most glucose transporters are insulin independent, insulin insensitive. Your glucose would go down even if no insulin was around. And insulin has lots to do with inflammation. Whenever you eat, insulin regulates the expression of the receptors in membranes that show if they have molecules from bacteria or viruses or from their own genomes. So, and this is, I mean, perhaps, yeah, without getting too technical, but think of it. Whenever we eat, we are acutely exposing our immune system to lots of different molecules that do not belong to our body. Food is arguably our largest exposure to foreign molecules. And our body needs to manage to tell the difference between safe and delicious and harmful or lethal. So it makes lots of sense that one of the molecules that changes the most whenever we eat, insulin, is also linked in facilitating the expression of what will help tell the difference between healthy and delicious or rotten and harmful. So insulin has lots to do with inflammation. Do we know exactly which molecule with which interaction goes and causes this? No. But yes, insulin could be a good part of the story, which is why, I mean, if insulin is a good part of the story, then that would mean that carbohydrate restriction is more important because you can have high insulin and high BHB if you're supplementing it. But if low insulin is what's needed, you would only get that with carbohydrate restriction. So again, open question.
Yeah. Okay. And so in order, so to bring this back to the whole sort of low insulin levels and sort of ketosis. So I would say my understanding is that in terms of increasing, say, the ketone bodies, there's really two options. You could either produce a state of ketosis either through the way that you eat or by fasting potentially, or take a exogenous ketone supplement.
Yep.
Yeah. And that's
supplements are not fasting in a bottle. They are very different. They are not I mean, any supplement. I mean, MCTs, ketone salts, ketone esters, free BHB. I mean, all of them have in common that they will raise BHB in your bloodstream. Yes. Are they interchangeable? No. I mean, they are very different in their chemical properties, safety profile, physiological consequences. Are any of them interchangeable with fasting or with carbohydrate restriction? Also no. Because you could have high insulin and high BHB, and you would never get that with a ketogenic diet or with fasting. So they are not physiologically equivalent to carbohydrate restriction or fasting. So yeah, there are two options for raising BHB, but not necessarily two equivalent options for medical treatments. I mean, as I already said, you can supplement ketones all you want, and yeah, your glucose will go down slightly, but it won't have the same impact as carbohydrate restriction for diabetes in the case.
Yeah. I mean, I think we've got a little bit of time left, and although there's a number of questions that I could ask you. So bringing it back to the research, I wonder, so these sort of identified, so as we mentioned near the start, you've identified sort of a set, shall we say, biomarkers that could be used to kind of identify or pinpoint this subgroup. I wonder, sort of how would these be used, say, in clinical practice to improve migraine treatment? In other words, what would this mean for patients suffering with migraine? I appreciate, obviously, there's a long lag time between doing the research and getting the research into clinic, of course.
I mean, part of what we try to do is provide the most useful ones, both statistically and clinically. Let me put you an example. Cortisol. Cortisol also emerged when we were doing our analysis as having information. However, cortisol measurements are very rare, and they require you arriving and giving your blood sample at a specific time in the morning, and not all labs have them, and they're not as convenient. So we try to bridge the gap you're mentioning between research and clinical practice by choosing the more available ones. However, and this has two implications. In today's world, I mean, at least in the United States, and certainly Mexico has a similar metric. It's very likely you live with a diseased metabolism. 85% of people in the States have insulin resistance. So I would say that even if you don't have migraine, you want to know if you have markers of fatty liver disease, pre-diabetes, inflammation, chronic inflammation. So these are also markers that perhaps you want to test anyway, because in today's world, lots of people live with diseased metabolism. If in the process of learning more about your metabolic health, you are living with migraine and have one of these metabolic markers, an abnormal value in one of these metabolic markers, you might as well try. I mean, the adverse effects and the entry cost of trying carbohydrate restriction or a ketone supplement is very low. Yeah. And it could help both things. It could help your metabolism, and it could help your migraines. You might as well try. I mean, these are part of the idea of putting forward these markers, is that these are things that you likely want to test anyway. And if you have a diseased metabolism, perhaps you want to test anyway if changing your diet will help. And you can get lucky and get two birds with the same stone.
Yeah.
So I think go for it. There's certainly not the only thing you can lose perhaps is a little bit of time. You will learn more about your relationship with food, which is also a good thing to know about. And we're trying to say that every clinician who sees people living with migraine should absolutely use these metrics all the time. I prefer to talk to the patients and tell them, well, are you sure you are metabolically healthy? If you live with migraine, these two things could be linked and therefore could have a similar intervention or benefit with the same metabolic intervention.
Okay, that's interesting. And we've got a couple of minutes left. So let me, before we run out of time, do you want to sort of let people know sort of where they can find you if they want to sort of contact you or anything like that?
Sure. I am, if you look at Twitter or X or whatever you want to call it, it's Twitter. It's at Adrian Sotomota, Sotomota. And my email is adrian.soto@tec.mx.
Okay.
And yeah.
Okay. Yeah, that's great. I really appreciate you coming on, actually. That was quite interesting. There's a load of more questions I could ask you, but I don't want to take up too much of your time. And
it's happy to come back and talk about them.
Yeah. But yeah, no, thank you again. I really do appreciate it. This was fun.
Thank you for having me.
No worries. And